Hi there and welcome. My name is Dr. Marlena Jabara, and I'm the proud founder of RadPodSquad. The RadPodSquad Fellowship offers an immersive learning experience tailored specifically to podiatric imaging. RadPodSquad combines comprehensive curricula, cutting-edge techniques, and on-demand access to training that will provide you with the new knowledge and skills that you need to boost your confidence in imaging and truly make a difference in treating your patients. Check us out today, radpodsquad.com. Welcome back to Plantar Plate Imaging. We're up to part 2, Plantar Plate Pathology. Nice to see you back. My name is Dr. Marlena Jabara, and I'm a board-certified American radiologist specializing in podiatric radiology. Let's take a look. Again, this is what we're trying to prevent, the classic crossover toe seen with usual second MTP or metatarsal phalangeal plantar plate tears. What happens here is that the plantar plate tears and creates a metatarsal malalignment which rotates the second MTP over to the first. So what we've seen usually is that there's tears of the lateral plantar plate at the second MTP joint, which crosses over to the second toe. And ulcers can cross and be created deep to the crossover toe, which can be a devastating complication in the diabetic foot. Taking a look at forefoot biomechanics through reading of our x-rays, after we've gone through our usual interrogation of reading a normal x-ray, which in the forefoot will include not only looking for fractures, any kind of transverse infraction, of course, looking for AVN, looking for Freiberg's infraction, understanding the alignment that the second metatarsal base needs to articulate with the middle cuneiform, that we don't have any Lisfranc malalignment. We begin to further look at subtle clues of the biomechanics. And in this case, again, we can see here that the thickening of the cortex may indicate an increased biomechanical load or even a prior healed stress fracture. We can begin to understand the alignment of the first MTP joint and the position of the sesamoids. Are they rotating towards the first interspace? Something that can be seen with uncompensated biomechanics, including rear foot varus. Take a look at the overlap at the metatarsal bases. Is it overlapping to a greater degree? Do we have the second, third, fourth all overlap? Or are they underlapped in a case of forefoot eversion? So we're looking for forefoot overlap, which is a common finding when we see overload at the medial aspects of the first and second MTP joints. So in addition, we can see in this case, there's even a subtle sclerosis seen in the proximal phalangeal bases. And how we can tell that is that in the normal state, the epiphysis is generally becoming fatty. And here we can see even the relative sclerosis to lucency, we can see there's an increased degree of sclerosis in this portion of the articulation. In addition, on lateral projections, we can pay close attention to the detection of hammer toes. And this is a great place to stop and see. Hammer toes are generally a result of hyperextension at the MTP and a flexion, a compensatory flexion at the PIP. Of course, we can have toe clawing, where we can have flexion deformity at the PIP and DIP in a state that can be seen also in neuropathic articulations. And of course, mallet toe is a different entity where we have flexion deformity reserved just for the DIP joint, and usually the PIP joint is in extension. So these are close things that we can pay attention to when we're looking to see whether or not we have malalignments that may indicate that we have increased forefoot biomechanical overload. Of course, we can always look for second toe crossover, which we don't have here, but what we do have here is a subtle malalignment deformity between the second DIP and the third DIP, almost on the order of a bowing or splay deformity seen here. In further reviewing anatomic considerations of the lesser metatarsal phalangeal joints, we can take a look at a metatarsal and the proximal phalangeal base, reviewing that that's supported at its plantar aspect by the plantar plate, identified here as the small triangular shaped basket structure. That's going to join your accessory collateral ligament to the deep transverse metatarsal ligament and form further reinforcement at the medial side. We can see that that's further reinforced at the level of the metatarsal phalangeal joint with the interosseous and the lumbrical tendon. And of course, superficial to the plantar plate, we have our paired flexor digitorum brevis and flexor digitorum longus with a tendon sheath. We have the neurovascular bundle, which is superficial to that DTML. Of course, we have the intermetatarsal bursae on either side to help cushion different rotational pressures that the metatarsal has experienced during metatarsal head purchase. Looking at the anatomic considerations of the metatarsals as they're lined up from M2 to metatarsal 4, we can appreciate the plantar plate as it joins that accessory collateral ligament and the proper collateral ligament superficial to that. And of course, our DTML, our deep transverse metatarsal ligament. We can appreciate the location of our neurovascular bundle. This will be the source of where we either find a pseudoneuroma, something that is a pericapsular fibrotic change to the nerve that's hugging the actual plantar plate, or whether it's centered midline, which would be a typical Morton's neuroma that's felt to be created by the pressure against the DTML. And I'll talk about that again in further tutorials. Looking at plantar plate imaging, we can appreciate the gross anatomic specimen seen here on the left with its 2 centimeter long plantar plate and about 2 to 5 millimeters in thickness and about 5 to 8 millimeters in width. Dissecting through the dorsal apparatus, we can divide the extensor tendons, exposing the metatarsal phalangeal joint, resecting the metatarsal head. We can expose that plantar plate seen here in the gross specimen, picking up the plantar plate where we can appreciate that 2 to 5 millimeter in thickness that we can see here, again, about 5 to 8 millimeter in width and 2 centimeter in length. Looking at plantar plate imaging with MRI, we really can appreciate that pericapsular thickening. We can see tears, ganglia, pseudoneuromas, cartilage loss, bone changes, and of course associated metatarsal head, rotational malalignments, metatarsus adductus deformities, and even forefoot varus and valgus. We can see here on these examples, the plantar plate has been retracted and pulled away, and we can see a gap that's greater than 2.5 millimeters. Here we can see that transverse greater than 50% of the thickness of the plantar plate and the pericapsular soft tissue change that has infiltrated this T1 weighted image. Looking at the clinical grading of plantar plate tears, it helps to understand the tear of what you're trying to diagnose prior to looking at the image, understanding grade 0 being normal, grade 1 being less than 50% of the tear of the thickness along that plate that we've been looking at. And of course, grade 2 can go completely across, but it still does not actually lose all of the fiber strength that's still reinforced at the medial and lateral aspects of the capsule. So grade 2 can be complete transverse tears. Grade 3 is a combination of 7 or T or an inverted 7 shape. And grade 4 can be an extensive tear with buttonholing so that the metatarsal head can probe through a defect and have a dislocation. Looking at plantar plate direct and indirect tears, we can see it just like I explained in that first example. The plantar plate here has been torn and retracted and there's a gap. And that's a direct sign, as opposed to an indirect sign seen here, where we can see that there is bone marrow edema along the proximal phalangeal base, but we can also see the plantar plate. But indirect signs that we're having a plantar plate tear is the increased stress that the proximal phalangeal base is experiencing, and also the presence of this pericapsular inflammation called capsulitis. And when we're looking at transverse images, we can appreciate the soft tissue swelling deep to the plantar plate region. In addition, we can see the actual irregularity in the region of the interosseous tendon and plantar plate tear as it attaches along that deep transverse intermetatarsal ligament. So we're seeing a plantar plate tear here. And of course, we're seeing bone marrow edema at the proximal phalangeal base in this patient that has a direct evidence of a plantar plate tear and actual stress response at the proximal phalangeal base. Looking at anatomic considerations of plantar plate tear, we see a direct tear. We see a gap of greater than 2.5 millimeters, not in the midline, and we can see that the plantar plate itself has retracted. Furthermore, tear has been described as thinning. Chronic tears can be thinned and attenuated. Again, we're looking for those types of tears going from transverse low-grade tears of grade 1, where they're transverse less than 50%, or grade 2 fully across, to grade 3, where there's a longitudinal extent of the tear. And of course, those inverted T or 7-shaped grade 3 tears, or of course, buttonholing tears at grade 4. Here we can see that this is a transverse tear that's extending greater than 50% of the way from the level of the region of the recess through that medial side. So this would be on the order of a grade 2 type of tear. Secondary signs include plantar capsulitis seen here. Looking at the interosseous tendon thickening seen here, that collateral ligament tendon thickening is demonstrating plantar capsulitis, that this patient is experiencing a pathology consistent with a partial tear of the plantar plate with plantar capsulitis and interosseous tendon thickening. Taking a look at anatomic considerations in pseudoneuromas, pseudoneuromas have been discovered to be associated with plantar plate tears, and this is where you have pericapsular fibrosis that is associated eccentrically with the plantar capsule. So in this case seen here, we can see this enlargement of the nerve and the pericapsular fibrosis or inflammatory change that's lying closer to the joint capsule and seen here contiguous with the plantar plate tear itself. And how we'll assess these will be to drop a bisecting line through the region of the proximal phalanx or the metatarsal region. And we want to see whether or not the perineural fibrosis seen here lies closer to one capsule or another. And if it's eccentric and lying closer to the plantar capsule, we can term this pseudoneuroma. And pseudoneuromas have been an important secondary sign in detecting plantar plate pathology. Are you ready to take your podiatric imaging skills to new heights? Check us out at RadPodSquad.com. Explore our online learning community. And don't forget to like and subscribe to our YouTube channel for more enriching content.